miss someone? Have you ever shared? Do you need someone to always be there?
Hello again, I'm Dr. Hung Vu and our show is America's Healthcare Crisis. The title for our production tonight is Leadership in Organized Medicine, Part 1. The practice of medicine is currently going through rapid changes, and many of those changes have such significant impact that they are appropriately called revolutionary. Obviously, during these times of great changes, we need a strong leadership in medicine. A leadership that understands the issues, that has the courage and the vision to take actions to hopefully bring about satisfactory solutions for our troubled healthcare system. And we're very fortunate to have with us tonight a very articulate speaker who has been personally involved in many facets of organized medicine. And I'd like to introduce him, Dr. John Granato. John.
Thank you very much. You're very kind.
Welcome to our show.
Thank you. Pleasure to be here.
Dr. Granato is a urologist. He's practicing in San Jose, and he was the past president of the Santa Clara County Medical Society, and he's also currently a member of the Board of Trustees of the California Medical Association. In addition, he's in charge of the continuing quality improvement process at Alison Brothers Hospital in San Jose. And I'm very honored to have him with us here tonight. John, why don't you give us a brief history of organized medicine as you see it?
Well, I guess most people would equate organized medicine with the American Medical Association. The American Medical Association was actually started by Dr. Nathan Davis and some of his colleagues and met for the first time in 1847 in Philadelphia. So this is actually the 150th year anniversary of the American Medical Association. The California Medical Association was actually founded a relatively short time later in 1856. And the Santa Clara County Medical Society, our local association, was actually founded in 1876. So all of them are more than 100 years old. Mm-hmm. The state medical associations are components of the AMA, and the county medical associations are components of the state society. Mm-hmm. And there is proportional representation at various elected bodies from these components.
Mm-hmm. Mm-hmm. And actually, you just mentioned to me that the state of California has currently about 20,000 members.
About 22,000 active members, yes.
And that's about 50% of the total count. Of
approximately,
patients.
Yes.
Yeah. What are the requirements of memberships?
Well, an individual must be licensed to practice medicine, must be in good standing, of good moral character, and agree to adhere to the canon of ethics of the American Medical Association and the California Medical Association.
Mm-hmm. And what is the process of terminating membership?
Well, membership can be terminated for violations of ethics or criminal activity. Mm-hmm. And as a matter of fact, if someone is convicted of a felony, they almost always lose their membership in the component medical association.
Mm-hmm. Now, every so often I receive a newsletter from the Board of California Board of Medical, what do you call it?
Medical Board of
Medical
California.
Board of California, giving the names of certain physicians who have disciplinary actions from the board. Two questions. If they are members and they come to ask for help, would the CMA help them defending their case? And secondly, if it's indeed they are guilty of whatever the board says they are, then are they automatically eliminated from the association?
Well, first of all, the publication you refer to, their so-called hot sheet, lists accusations. And that has been a source of discomfort for physicians in the state because that's what they are. They're accusations. They are not proven fact. If an individual is accused by the board and found to have violated some medical activity, that will be reviewed by their component medical society. And if sufficiently egregious, if they have lost their license, then they will lose their membership in the medical society.
You haven't answered the first question.
I'm sorry, what was that again?
If they have a case that is
the CMA does have a legal defense fund, but they have not generally participated in that type of a process. Most of the legal defense fund have been used for sentinel cases where there are very important principles of physician autonomy and practice involved. However, recently CMA has had some discussions with the Medical Board of California about having a CMA representative present during hearings if the CMA member asked to have such representation. This would not be a legal representation per se, but there would be a physician there to monitor the process to be sure that the physicians were being treated fairly.
That's very good. As you know, the reason I asked this question is because physicians are having a very tough time now.
I agree.
Traditionally, the profession is such that, because it deals with life and death, of course, that it's almost expected that you cannot be wrong. You know, you may be practicing good medicine for 30 years, and then you make one mistake, and then something happens to your patient, you may lose your career. And to me, it's very frightening prospect. I have personally known of physicians who are in such dilemma. And I think that matter of fact, I was a member of the society for a while back, and if I would be again, that's exactly what I would expect from my society is to come to my defense. If I'm attacked, and physicians are attacked from all sides now, patients, HMOs, bosses, consumers, groups, we're just very isolated, So I do think that one of the privileges of the membership would be to have somebody to depend on, to rely on in case of trouble.
Well, ideally that would certainly be the case. CMA has a very skilled legal staff, but they are really overwhelmed just dealing with the types of cases that I've already described. And it's not really practical, it's not economically feasible for CMA to undertake to represent physicians in malpractice cases or appearances before the Medical Board of California. However, I will say that there are means for physicians to avail themselves of legal insurance, so to speak. Santa Clara County Medical Association, for instance, has made arrangements for physicians for a fee to be insured, so that should something of this nature come up, that they will be represented by an attorney. And of course, if it's a malpractice issue, then a prudent physician has malpractice insurance, and the liability carrier then provides legal representation.
Yeah. Tell us a little bit about the organizational structure of the different bodies of organized medicine. You mentioned that it started from the membership, and then the second level would be delegates. And why don't you go on and give us an idea as to how
Well,
it's organized?
the county society has a board of trustees, which we call the council. And they are elected by the membership. They are, in theory, they represent what we call counselor districts. The counselor districts roughly correspond to the major hospitals in the area. And as a practical matter, most of the time, the counselor represents a particular medical staff. There are representatives from each of the major hospitals in the area, including Stanford, although not the VA hospital. The county hospital is represented as well. They have their own counselor.
So Stanford is not represented, you say?
Stanford is represented.
It is,
The
okay.
only hospital that really isn't represented is the VA hospital.
Okay.
And this is the governing body of the County Medical Association. The County Medical Association is a component of the California Medical Association. And the policy-making body of the California Medical Association is the House of Delegates. And each county society elects a certain number of delegates to the House of Delegates based on their membership. And those delegates then meet once a year. And it's a process very similar to our national legislative process. But instead of bills, we call them resolutions. Physicians are free, members are free to introduce resolutions. They are then considered by reference committees, which are roughly equivalent to committees of the House of Representatives and the Senate. And then they vote them out and make a recommendation that they be accepted as written or rejected or accepted with certain modifications. And then those are voted upon by the House of Delegates, and they then become the policy of the California Medical Association. And there is a similar process with the American Medical Association. Each county society, depending on its number of members, is empowered to elect one or more delegates to the AMA, House of Delegates, which also meets on a regular basis. The delegates then elect members to the Board of Trustees of the California Medical Association, and the delegates to the AMA elect members to the Board of Trustees of the American Medical Association. And the Board of Trustees is then charged with carrying out the policy that's been made by the House of Delegates, either of the California Medical Association or the American Medical Association.
What is the duration of service for a member of trustees? 2 years, 3 years?
A trustee in the California Medical Association may serve 3 consecutive 3-year terms. So the total membership would be 9 years. Yes.
Okay. Let me just address the very sort of pressing issue now for physicians. There's a great debate on the fact that there is a surplus of physicians everywhere. In particular, my reading is that in California, the primary care physician, internist, general practitioner, is at about 18% surplus. And to certain specialties, it's upward to like 70, 80%. So what is organized medicine doing about influencing the medical schools in curbing the training of specialists and increasing the numbers of generalists?
Yeah. I'm not sure about the figures you presented. I'm sure they are accurate. I don't personally know those figures offhand. But I will say that traditionally there has not been great participation by academic physicians in organized medicine, which is unfortunate for organized medicine and for the academic physicians. However, with the advent of managed care, the academic physicians have found themselves at a disadvantage because a lot of the funding for graduate medical education came through the Medicare and Medicaid programs. And as managed care has come into the market, lots of money has been lost for graduate medical education, which is a problem for the medical schools, so that they are now becoming more interested in being represented by organized medicine. And that's a good thing. But up till this point in time, there has been disagreement among physicians as to whether or not some type of a manpower policy for medical manpower is needed or is even desirable. The medical students have resisted efforts to cut down on the number of specialty slots available because they consider that a coercion to make them become involved in primary care. They agree that there is greater need for primary care physicians, and larger numbers of graduating medical students are going into primary care. But they don't want to lose the opportunity to become specialists if they desire to do so. There have been a number of studies that have recommended that medical schools be closed entirely, and that the numbers of graduate medical education positions, residency training positions, be limited. And there certainly have been some efforts, and they are accelerating, to limit the number of specialty training positions that are available. But there's controversy there as well, because there are many international medical graduates, that is, physicians who have graduated from medical schools that are not in the United States or Canada, who are American citizens, who would then be deprived of an opportunity to train here in the United States. So it's not without controversy. My own personal opinion is, and this is a personal opinion, that manpower needs to be addressed as an issue. And many people construe that position as being a vested economic interest, and it isn't. The fact of the matter is that many specialties, particularly surgical specialties, but even technical medical specialties, require a lot of repetitive effort to maintain the skills that one acquires.
Right.
And with large surpluses of specialists, individual physicians simply do not have the numbers of patients to maintain those skills.
Absolutely.
And I think there will be a diminution in quality as a result of that. And that's why I feel strongly that there needs to be a manpower policy.
Okay. Now we're talking about leadership, is the title of our show. What is your evaluation? You have been personally involved in several very important positions and activities of organized medicine at certain different levels. What is your own evaluation of our leadership?
I think that we have, by and large, very good leadership. I really do. The people that I have served with, both at the county level and at the state level, are all well-trained physicians, well-motivated physicians, who I believe have the interests of patients as their primary concern, and the interests of their fellow physicians as well. You know, why we are in the position we're in now is difficult to determine. One of the reasons certainly is that the government, I believe, misread the incentives for physicians and created lots of training positions, opened new medical schools, in the belief that by increasing the number of physicians, they would increase competition and drive down the cost of medical care. And that didn't happen. It just generated additional costs. And although physicians deserve to be, in my view, and obviously want to be well compensated, most physicians are happiest when they're busy, when they're seeing lots of patients. And I think if the government had created incentives for physicians to see more patients, many of the excesses we see now would not have occurred. But they did occur, and the cost of medical care escalated, and the purchases of care, primarily employers, realized that when they spent more to manufacture a car on providing health care for their employees than they did on the cost of the steel that was involved in manufacturing the car, something had to change. And that's why we have managed care at this point in time. But the mistake that most physicians make, or many physicians make, is that they view managed care as a payment mechanism. And managed care is not a payment mechanism. It is an approach to the practice of medicine. An approach to the practice of medicine. The payment issues are real issues, but they are not managed care. Managed care means what it says, to actually manage the care of the patient so that the patient receives the best care in the most efficient manner. And that's something that physicians ought to strive for.
Well, my understanding is that the managed care system is the inevitable result of the inefficiency of the way we practiced before autonomously. As you know, for a long time, physicians call the shots, and they just practice in a widely different fashion, and the cost can be difference in cost can be enormous, and that is the reason why managed care was born, to curb the unnecessary utilization. And like you say, the definition is to provide the best of care, whatever that means, at the most efficient or the least affordable cost. Now, it's just, to me, the economic equation could not be forgotten, because just look at any typical hospital like El Camino Hospital, or even in the Stanford area. I understand that there are one physician or even a specialist for maybe 200 or 300 patients living in the vicinity. So obviously, in order for those physicians to generate a certain income, to live a certain lifestyle that they expect after so many years of training, there has to be inefficiency and overutilization. There's no way I can see that, like say, a cardiologist who is trained to take care of heart diseases can make a decent living serving 200 patients. I mean, to me, there has to be a strong consideration in terms of incentive. In other words, the distribution of physicians is such that they're concentrated in certain areas, and those areas do not necessarily provide better care. It's just more inefficient care, I would think.
Well, you've certainly touched on another issue. Not only do we have too many doctors, but they are maldistributed. I'm certainly not an expert in that area, but my view after listening to many people is that while we may be able to address the issue of the excess, the maldistribution is a problem that may be beyond our achieving a solution.
Yeah.
By and large, physicians are educated, sophisticated people who enjoy living in urban areas with all the benefits that one has from living in an urban area. it may be possible for the government to create incentives to get people to practice in more rural areas.
Mm-hmm.
But so far, no one has achieved success in
Yeah.
that regard. And there's no doubt about it. California has the highest ratio of physicians to population of any place in the state. In the States, in the Bay Area, I think is higher than any place in
Yeah, that's right.
California.
Right. I think we're running out of time. We just had a very interesting and informative conversation with Dr. John Granato, urologist who has been an active member of several different medical associations and outshows America's healthcare crisis. I'd like to invite you to watch the second segment of our production with the same topic, leadership in organized medicine. This is Dr. Vu. Thank you for watching. Good night.
Do you love someone? Have you ever cared? Do you miss someone? Have you ever shared?
That was very good.
Do you need someone
No, they're turning down
to always be
the
there
audio now, so.
when you feel lonesome and deep in despair? Do you need someone to dry up your tears? Do you need someone to always be